So first, basically embryology ante the gene SRY gene, that is sex determining gene on Y chromosome. That is the gene which is responsible for the differentiation of the embryo into a male or female. Ante male form avvalante this gene has to be expressed. So what will happen is initially till 4 weeks till 6 weeks, like this gonad will be undifferentiated gonad. After that, under the influence, after 6 weeks, under the influence of genes, it will be determined whether the testis has to form or gonads like ovary has to form. So, in embryology law, the main thing is this genital ridge. The genital ridge near the abdomen, this is the first thing which from where this male reproductive system start developing. And then what will happen is the genital ridge dagra lot of sex germ cells అనేది they will migrate and come near the just genital ridge. And then there will be some amount of mesoderms, intermediate mesoderms అని కొన్ని mesoderms ఇక్కడ ఉంటాయి. And then along with that some few cells will be multiplied from this epithelium near the this genital ridge. అట్లే we have lot of like all kind of tissue అంటే mesoderm, epiderm, endoderm, everything we have here, and then this will slowly develop into this germ cells will slowly it will divide and it will form few cells like settled cells, leading cells, and then they will form this seminiferous tubules, everything. So the basically it is like genital ridge and then germ cells migration into the genital ridge and its proliferation, and then along with SRY gene will end up in testis development. So the same thing I have put it here. So the sex of the embryo అనేది initial గా till 6 weeks, 7 weeks it won't be determined. After 6 weeks only it will be determined based on the gene which is expressed. And then this gonads is initially formed as a genital and the gonadal ridge, and then slowly, like as I told, this germ cells will migrate along the hindgut and then it will be arriving this genital ridge. And then this just a minute.
అదే అది థర్డ్ ఉంది కనపడుతుంది అక్కడ ఎవరు వస్తారు అది చూడండి నేనే చూస్తాను.
Okay. So that, as I told before, this genital ridge proliferate. Along with that mesoderm also proliferate and it forms a few sex cords that is called primitive sex cords. And then this it will be indifferentiated till 7 weeks. After that, till 6 weeks. After that, it will be differentiated. The So, how testis is formed is like, as I told before, SRY gene, the primitive sex cord continue to proliferate and it penetrates deep into the medulla and it forms the medullary cords. And then in the hilum, again, this will break up and it forms a multiple cords that is called retitestis. And then during further development, there will be a fibrous connective tissue that forms tunica albuginea. And then testis cord or is basically it's nothing but a primitive germ cells and then Sertoli cells which is derived from the surface epithelium. So Sertoli cells is derived from the epithelium and then this interstitial cells of leading cells is derived from the mesenchymal cells of the gonadal ridge. So initially till they begin development shortly after the onset of differentiation of these cords. So till by the 8th week of gestation, the leading cells will produce testosterone and it is the reason for the sexual differentiation of the genital ducts and the external genitalia. So this testis will remain as a solid structure till the puberty and then after puberty it will form the proper seminiferous tubules. So once this seminiferous tubules is formed, then it will connect with the retitestis which in turn connect with the ductus efferents and it forms the proper male duct. So testis will produce testosterone from the leading cells, which is necessary for the development of mesonephric ducts. And then testis will also produce mullerian inhibiting substance from the Sertoli cells, which will suppress the paramesonephric duct. So this is in short few words about embryology. And then as I told you before, in males, this SRY gene will be expressed maybe around from the 6th week and then this will increase the expression of SOX9 gene. This XOX9 gene will suppress these two genes that is DAX1 gene and WNT4 gene which will causes the suppression of the female organs and then the male organs will be expressed. And then this SOX9 will further increases the SF1 protein, which is gene, which is needed for the formation of the testosterone enzyme, sorry, testosterone hormones. Testosterone in turn is needed for the development of all the internal organs of the male. And then dihydrotestosterone, which is the byproduct of the testosterone, is necessary for the formation of the male external genitalia. So this is about anatomy. So here is the testis. You have seminiferous tubules which connect as a retitestis and then it will open into the epididymis. Again in epididymis they have a different parts that is caudal part, body and then distal part, head part, body and then distal part and then it will open into the ductus deferens and then at the posterior part of the bladder this ductus deferent in fusion with the seminiferous tubule opening that is duct it forms the ejaculatory duct which opens into the prostate and then from there the sperms will be entering the urethra sorry. The same thing, the seminiferous tubules will end up in retitestis, that will end up in efferent ducts, that will end up in epididymis, that will open up into the ductus deferens. So this is again structure of the seminiferous tubules. So this round one is the seminiferous tubules. It has a Sertoli cells, which is a supporting cells. And then next to this Sertoli cells, we have all those spermatogonium, and then which is mature and it will end up in a spermatid, spermatozoa, which will appear in the human. And then this leading cells will appear like it will be like present in between the tubules while the Sertoli cells is presented within the tubules. So this is again Like this is the basement membrane, this is the spermatogonia, and then again after few divisions, like after mitosis, it will become a primary spermatocyte, and then further it undergo division, and then finally it forms a spermatozoa, which is appear in the lumen. So basically, the seminiferous tubules consist of those germ cells and the supporting cells. The germ cells is nothing but those spermatogonia. Those supporting cells are nothing but the Sertoli cells. Slowly, from those cells, the sperms will divide and then it will end up in a spermatid and spermatozoa. So this something about Sertoli cells. They are lined. This seminiferous tubules. Yeah, this I have already told. The seminiferous tubules are this Sertoli cells are arranged near to the basement membrane, and uh, it forms the support for those seminiferous tubules. It's basically a supporting cell. This Sertoli cells serve as a nerve cells for spermatogenesis. This is very important for the spermatogenesis to happen because this Sertoli cells will make that microenvironment which is suitable for the spermatogenesis, and then it forms a testicular barrier. So it supports the germ cells through a gap junction between the germ cells and the Sertoli cells and the other supporting cells nearby. Along with the germ cells, it's form a tight barrier, and then this barrier will helps the sperm from exposing to immune system. So it doesn't expose to the immune system because of this testicular barrier. And then this also allows the migration of the germ cells from the basement membrane to the tubules. And then this Sertoli cells also release an androgen binding protein which has the capacity to bind to the androgen, which is 50-fold higher than the serum. So this testis will be highly concentrated with the testosterone because of this androgen binding protein. So it will be rich of testosterone, which helps in the spermatogenesis. So this is the blood testis barrier, which I have told. It is a junction between the Sertoli cells, germ cells, spermatogonia, along with the nearby all those supporting cells, fibrous tissues. This is very important because this prevents the sperm from exposing to the immune system. So a few words about physiology. As we know, so all our endocrine systems is under LS and FSH control. So from hypothalamus, GnRH will be released in a pulsatile manner, and then which in turn act on the pituitary, and then FSH and LH will be released. So in the gonads, this LH act on the leading cells, and then this leading cells, that is which is present outside the seminiferous tubules, will produce testosterone. Excess testosterone will have a negative effect on LH. On the other side, FSH act on the Sertoli cells, and then it forms androgen binding protein. So this androgen binding protein, it will move through the basement membrane and it will attach to the testosterone, and it will take the testosterone into the Sertoli cells, into the seminiferous tubules, and it helps in the maturation of the germ cells. So the Sertoli cells also releases the hormone like inhibin. So basically, it is physiology is about the HPO axis, anterior pituitary hormones, FSH, LH, and the testicular level. It is a testosterone production and the sperm production. HPO axis acts at these four levels. So as you guys know, it is GnRH hormone will be released. It released in the pulsatile manner every 90 to 120 minutes once, and it acts for almost some 2 to 3 minutes or like 5 minutes. and then FSH LH will be released. And then, as I told in the picture, LH act on the leading cells, FSH act on the Sertoli cells, and then it is the important stimulator for the seminiferous tubule growth. So, FSH is the essential hormone for the initiation of the spermatogenesis at the puberty. So, in the adult, what will happen is till the baby is intrauterine, all these hormones will act. Once the baby is out, it will have this hypothalamus pituitary axis will be inactive. So all the testes will be like they will be like it's like a cord-like structure. Once the axis is released, the FSH will start producing, and then it will start acting on the gonads, and then it start producing spermatogenesis, and then proper seminiferous tubules, everything will be developed. So in male, prolactin also plays an important role, prolactin hormone. It will increases the concentration of the LH receptor on the leading cells. That how it sustains the intratesticular testosterone level. That is also one reason. So if there is a prolactin abnormality, it will affect the male libido, like male sexual desires. So hyperprolactinemia will affect the pulsatility of the GnRH release. So the normal testosterone production in male is around 5 grams per day, and it is released in a pulsatile and the irregular manner. Though this testosterone is metabolized in the target organ as dihydrotestosterone by the action of 5-alpha reductase, which helps in the development of external genitals. And then this also, through the action of aromatase, it will release some amount of estrogen too. So this all those things I think I have told you in that picture. I have told you about the negative feedback mechanism also for the LH and FSH also. So if FSH is more, this FSH will cause more of inhibin release. That inhibin release will have a negative effect on the FSH, whereas excess testosterone will have a negative effect on LH. So testosterone is needed for the internal genitalia formation, and then dihydrotestosterone is important for the external genital formation. So this also I have told you, like till when the baby is intrauterine, it will be active, and then there will be formation of some testosterone, there will be formation of this Sertoli cells and all, and then after the withdrawal and the placental steroids at birth, there will be a high gonadotrophin secretion in the neonate. So there will be a suppression of this axis. So once the boy has attained puberty, this secretion will start, and then it will start producing all those organs. Like it will start giving that enlargement of all those external genitals and all. The same thing. So spermatogenesis, initially it is a stem cell, spermatogonia, and then by mitosis, it will become a primary spermatocyte, and then by meiosis, it will become a secondary spermatocyte and spermatid, and then from spermatid, it will become a spermatozoa. From single germ cell, you will be getting 4 spermatozoa. So usually it takes almost around 3 months. It has a different phase. As I told, it is a mitosis, meiosis, and spermiogenesis phase. Spermiogenesis is nothing but when the spermatid becoming a spermatozoa is nothing but spermiogenesis. In spermiogenesis only, there are a lot of things happen. I'll tell you. So this is just a histological picture of normal spermatogenesis. See, this is the basement membrane. Near the basement membrane, you will be having spermatogonia, and then this will form a primary spermatocyte, and then followed by spermatid. Spermatid will become spermatozoa. See, you can see the proper like sperm head and tail. That will be near the luminal surface. This is just an example, like this is called maturation arrest, where the basement membrane has just the spermatogonia. It doesn't have any other cells. So in spermiogenesis, the important changes is happening. That is this in the sperm, from the spermatid to spermatozoa. During that process, the sperm is getting activated. That is, the nucleus will become elongated and the DNA will become condensed, and there will be a formation of acrosome, which is helpful for the oocyte penetration. And then there will be organization of mitochondria. Basically, the sperm will become mature when it become a spermatozoa because of all these DNA changes. So these are the changes which is happening when the spermatid is becoming a spermatozoa. Basically, the DNA is become too condensed, so that when it pass through the tract, so that nucleus will not much exposed to the oxidation. So the DNA damage will be less when it is become more compaction. So basically, spermatozoa, like after it entering into the epidermis, like in the epidermis, it start maturing. So what is happening is this sperm transport through the epidermis, it almost takes around 12 days. Here, what is happening is this mechanism other than so basically here the sperm will attain the motility in the epidermis, not in the, like again in the epidermis I have told you the different part, no? Exactly in the caudal part, it will attain the complete motility of the sperms.
చెప్పండి థింక్ లాజికలీ అందుకనే యు బ్రేక్ ఇంటూ దిస్ ఇనిషియల్ కాంటాక్ట్ ఇన్ బిట్వీన్ అసెస్మెంట్ ఫైనల్ ఈజ్ ఎగ్జామినేషన్ అది దట్ ఈస్ యూకే మోడల్ 9 months కోసం రన్ చేస్తున్నారు ఇదే.
So the sperm fertility maturation is finally achieved at the late carpus epidermis, that is end part of the epidermis. So there are some biochemical changes is also happening at the epidermis. What is happening is the sperm is expressing more of the negative surface of the negative surface at the membrane. That's how it is becoming very stable. So overall, what is happening is the changes which is happening in the epidermis is it makes the sperm strong, and it will make the sperm attached to the helpful for the penetration of the egg. This I have already told you. So other than hormonal changes, even temperature has an effect on the testicular function. So that's how varicocele and cryptorchidism will affect the male fertility. So the last thing is about a few parts about a spermatozoa. Spermatozoa is a sperm which has head, neck, tail. The tail has a middle piece, principal piece, and the end piece. The head has a acrosome or chromatin, which is helpful for the penetration of the egg. This neck is acting as a, this will connect the head and the tail. It has a few, it's act as a connecting piece, and it has a centrioles. This axonemal complex in the neck will, it helps in the, basically it supports the sperm by connecting the head and the neck. So, so this is the head, this is the acrosomal cap. So this acrosome is very important for the penetration of the egg. And then this is the neck piece. Neck piece basically it helps in connecting head and the mid piece. Mid piece has a mitochondria, which produce the energy for the sperm. And then this principal piece and the end piece is basically for the motility. So the same thing I have told here, I have explained. Thank you. So I think to an extent I try to cover the embryo part, something about genes, a part of anatomy, a part of physiology, and then regarding spermatogenesis, and then a structure about the sperms. So, so this is basically a introduction topic. So if anyone has any doubt, you can ask.
IMA నుంచి థ్యాంక్ యూ వచ్చేసిన ఏం చెప్తాం
Anybody have any doubts? So you have two class or you have a one class today? You have spermatogenesis and any other class do you have today?
Then regulation of menstrual cycles, something there.
Okay, fine. I think next, I think somebody else will be taking the class. They'll be
Okay.
continuing the class. I'm ending now. Okay.
Yes,
You
ma'am.
can still stay back. They will take the class.
So this evaluation in male for this regarding general question, madam. So whenever a couple is anxious to conceive and all, so they have had this 1 year of unprotected intercourse and all, finished 1 year. Now they have come. So as part of evaluation of both male and female, so when do we advise the male partner evaluation? Like what part of the cycle you are, like your general evaluation you have started evaluating the couple. So what do you recommend? What test do you recommend? And when do you suggest, in which phase of the cycle would you recommend if you are asking for a semen analysis? How do you proceed?
See, for semen analysis, there is nothing to related to phase of the cycle, right? So we just need 2-3 days of abstinence, and then we are doing semen analysis for everybody, not necessarily like somebody whoever visit the clinic with infertility, and then more than 1 year of more than 1 year they have tried, still they haven't achieved, still they haven't become pregnant, and they once they approach us, if they have a 3 days of abstinence, we are doing essay. That's it for
Yes.
everybody. We
For
just need
everybody.
2 or 3 days of abstinence. That's it.
When we see that the parameters are a bit on the lower side, so do you ask them to repeat the sample? If so, when do you ask them to repeat the sample?
Yeah, actually, if there is an abnormal report, we should know the reason for it, and they like smoking, alcohol, lifestyle, all those things I'll be asking. And then we should know what about their previous report, if at all, if they have done. If it is normal, obvious. Otherwise, also, if there is an odds, if there is an less count, mortality, whatever, it's always advisable to repeat it at least a month after. Generally, this spermatogenesis is 3 months, no? As per books, it is 3 months. But
Yes.
generally, we won't wait for 3 months, right? So we'll tell them all lifestyle modification, we'll put them on some antioxidants, and then we'll ask them repeat essay maybe after a month.
Mm. Which are the main concerning things, like in the semen analysis, low counts or something like when do you address them to like have a, if they have the parameters are abnormal, would you recommend, apart from putting them on these antioxidants, would you recommend them to meet a urologist or somebody like
No, generally we don't advise. See, when there is an severe wound, still we are not able to find out any reason, and then if FSH and all is high, at times like we'll send it to andrologist. Otherwise, we won't send them to andrologist. Like we'll tell them lifestyle modification, and then we'll give them, depends upon the testosterone estrogen ratio. For people whomever need this CC letrozole, we'll try to give it for 2-3 months, and then we ask them to repeat the essay. If needed, we will send them. Not routinely, we'll send to andro people.
Male factor, how often is it correctable, ma'am? Like most of the male factors, whenever they are there, we have to go for advanced.
Nothing, ma'am. No, we can't see major changes. See, when it is less than 10 million, just for the satisfaction, all these antioxidants we used to give. Otherwise, we won't see much difference. Even if we repeat it after some time also, no, we won't see much difference.
So if the male factor is there, will they be counseled for advanced procedures, madam?
దాంట్లో సౌండ్ క్వశ్చన్ మ్యూట్లోనే ఉందా?
Dr. Shilpa, I was
Recording
asking some
stopped.
question. My system got switched off. So, did I clear your doubts?
Yeah.
So, actually, it doesn't make much difference, yeah. Like,
Okay.
see, for example, if somebody's semen analysis, it is 8 million, 10 million, after giving antioxidant, it won't become 15 or 20. It will be around 8 and 10 only. See, it doesn't much help actually. Unless if there is some infection, unless if there is some varicocele, if any correctable problems are there, it can improve to an extent. Otherwise, if it is an idiopathic, there is nothing much we can do.
Yes, ma'am. I think most of the times they are not correctable. Only when there is a
Yeah.
or infections, I think they are correctable.
Mm-hmm.
They are not the reason for that thing. Then I think they should be counseled for advanced things only, like IVF and all.
Yeah.
Yes, ma'am. Thank you. Thank you.
Okay. Yeah. Hello?
Yes, ma'am.
Yeah, I'm audible, right?
Yes, you're audible.
Yeah, good afternoon, everyone. So today I'll be speaking about regulation of menstrual cycle physiology. So this is Dr. Grishma. So now I'll be covering about because hello.
Yeah, hi, ma'am.
Yeah. I have to finish the class before 4, I think, because again some other meeting is there for madam. So I'll
Okay,
speak
ma'am.
little fast.
Yeah.
So right now I'll be speaking about neuroendocrinology of hypothalamus pituitary, and then for folliculogenesis, early follicular phase, late follicular phase, ovulation, luteal phase, and luteofollicular transition. So as we all know, GnRH is a decapeptide. It is secreted from the hypothalamus. So the GnRH neurons appear in the medial olfactory placode and enter the brain. So because they arise from the olfactory placode and then enter in the brain. So in the Kalman syndrome, so there is hyposmia along with hypothalamo-hypopituitarism. And GnRH half-life is only 2 to 4 minutes. So it has to be secreted in continuous pulsatile form. So the measurement of LH pulses is used as an indication of GnRH pulsatile secretion. So again, this will act by the feedback effects. So this hypothalamus, pituitary gland, target gland hormones. So again, there will be 3 types of feedbacks like long feedback, short feedback, and ultra short feedback. So long feedback is like from the target gland, whichever hormones are secreted like estradiol or progesterone, they exert a inhibitory effect on the hypothalamus or pituitary. Then in the short feedback, again the pituitary gland hormones like FSH or LH, they again exert a inhibitory feedback on the releasing hormone from hypothalamus. So ultra short feedback is like same thing, the inhibition by the releasing hormone on its own synthesis, like GnRH or something on its own synthesis, it exhibits inhibitory effect. So again, all this GnRH pulsatile system is again controlled by some neurotransmitters. Then GnRH pulses. So we should be knowing what is the mean frequency of the pulse. So LH pulse mean frequency is like, so we cannot measure FSH pulse, we can only measure LH pulse mean frequency. So early follicular phase, it is around 90 minutes. Late follicular phase, it is around 1 hour. Early luteal phase, around 100 minutes. Late luteal phase is 200 minutes. So lower pulse frequency favors FSH secretion, whereas high pulse frequency favors LH secretion. So pulsatile GnRH secretion is more frequent. I'll be showing the diagram. Pulsatile GnRH secretion is more frequent, low in amplitude during the follicular phase. So here we can see in this diagram, first the low frequency pulses increase, then again when you are coming to the mid follicular phase, there will be increase in the frequency and amplitude, which will give rise to LH surge for the ovulation and the beginning of the luteal phase. Whereas again, during the late luteal phase, there will be like decrease in the GnRH pulse frequency, which favors like FSH synthesis and secretion, allowing the rise in FSH essential for the next cycle. So again, these are controlled by neurotransmitters like dopamine, serotonin, opioid, CRH. They exert a inhibitory effect on GnRH pulses, whereas norepinephrine, kispeptins, neuropeptide, they again exert activate the GnRH pulses. So this neuropeptide Y, what it does is it stimulates the appetite and also it activates the pulsatile release of GnRH. We all know that this GnRH, this release in it should be released in pulses. Whenever it is released in pulses, then only we attain puberty. So again, this neuropeptide Y is regulated by steroids. So what is its importance? Whenever we have like undernutrition, anorexia or bulimia, what will happen is pulse frequency will increase in neuropeptide Y will be there, so which will increase the GnRH pulse frequency continuously, so it causes down regulation and then it causes amenorrhea. Again, so this GnRH hormone is all regulated by this neuropeptide Y, kispeptins. So these are peptides. Kispeptins are encoded by gene KIS1 that is expressed in the hypothalamus. So what does it do? This kispeptin, this increases the GnRH. Again, GnRH, because it doesn't have direct receptors, so through the kispeptin mediation, it will be activated or deactivated. So these kispeptins are required for puberty onset and maintenance of reproductive function. So again, because if there is some loss of function or mutations of kispeptin receptor gene, again it will lead to hypogonadotropic hypogonadism. So again, these are located in the hypothalamus, and how it is regulated is, so what will happen is, because these KIS neurons, they will activate GnRH neurons through positive feedback or deactivate through negative feedback. What will happen is, whenever in the absence of estradiol, these neurons are
Recording
highly
in progress.
So these neurons are highly active, so they lead to elevated GnRH secretion, like negative feedback. So less estradiol, there will be more activation. Whereas whenever there is more of estradiol, KIS1 activity decreases. So this increased estradiol, this reduction of GnRH activity, this is seen usually, but except at the time of pre-ovulatory LH surge, because we all know that increased estrogen levels only cause this LH surge. So increased estrogen levels at the end of follicular phase, though estrogen levels are increased, again they activate the KIS1 neurons and then increase the GnRH pulse frequency and amplitude, leading to LH surge and ovulation. Then again, following ovulation, there is rise in progesterone, then again decreasing the pulse frequency. So these opiates also, they inhibit gonadotropin secretion by suppressing the hypothalamic release of GnRH. As such, they have no effect on the pituitary response to GnRH. So they directly inhibit the hypothalamic GnRH. So all these are this thing are regulated by GnRH, sex steroids, and peptide pituitary gonadotropin secretion. So GnRH regulation, whenever this thing binding of GnRH is there to the receptor in the pituitary, there will be like immediate response releasing like FSH, LH, or there will be delayed response like receptor activity may be increased like self-priming action. So estrogen. Low levels of estrogen cause FSH synthesis and storage, whereas high estrogen causes inhibits FSH secretion and also induces LH surge. Progesterone, low levels help in FSH surge as well as LH surge, whereas high levels inhibit the secretion of FSH and LH. So this is like two-cell, two-gonadotropin system, where we see that in the follicular phase, theca cells will have LH receptors, whereas granulosa cells will have specifically FSH receptors. So there should be some LH activity should be there in the early follicular phase also. So what does this theca cell LH do? It takes in the cholesterol, and then due to this P450 enzyme, it converts this cholesterol into androstenedione and testosterone, and then which is uptaken by the granulosa cell, and then it is again aromatized by CAMP mediation into estrone or estradiol. So thus ovarian steroidogenesis is LH dependent. So this LH regulates the cholesterol entry into mitochondria. Again, by the expression of this P450, which is a rate limiting step, androgens are formed. Then again, And from the androgens, this granulosa cell uptake will be there of these androgens, and then they are converted into estrogen by aromatase enzyme. So again, there is intrapituitary autocrine paracrine system. This comprises of like TGF beta family, which is activin, inhibitin, follistatin, growth factors, and endogenous opioids. So this inhibin, there is like inhibin B as well as inhibin A. So it depends upon the this thing, whether they are having alpha subunits or beta subunits, which are linked by bonds. So inhibin is secreted again by the granulosa cell. So what does this inhibin do? It inhibits FSH action, whereas it may enhance LH activity. So what we see is in the this thing early follicular phase. So because whenever there is more of FSH, whenever there is more of inhibin B, FSH will be less, as you can see. Whenever there is inhibin is raising, FSH is decreasing. Whereas after ovulation, no, again there will be more of inhibin B. So inhibin B peak is seen one day after ovulation, which is probably the result of release from the ruptured follicle. Then again, this granulosa cell will have LH receptors after ovulation on the dominant follicle, and then again this inhibin expression changes from B to A. So this granulosa cells also secrete activin. What does it do? Activin causes inhibin inhibits FSH, whereas activin augments secretion of FSH, and also it increases pituitary response to GnRH by enhancing GnRH receptor formation, and also activin peaks at menses to allow this to allow FSH rise during this transition. And also it prevents premature luteinization and progesterone production in the pre-ovulatory follicle. So again, this follistatin is secreted by the pituitary cells. This follistatin mainly acts by decreasing the activity of activin. So it acts like it inhibits FSH synthesis and secretion. So AMH. AMH is detected in the granulosa cells of early primordial follicles and reaches peak concentration in small antral follicle. So its secretion appears to be regulated by the mature oocyte. So usually AMH is secreted by the primordial follicles and also small antral follicles. So AMH decreases. So AMH, whenever there is more AMH, it acts as a brake. So AMH decreases whenever there is FSH. So for the follicle to grow properly, AMH this should be low. So AMH decreases whenever there is FSH stimulator follicular growth and estrogen production occurs. So what does it do? So whenever dominant follicle grows, no, this thing AMH, it inhibits the recruitment of other primordial follicles. So this paracrine activity of AMH inhibits FSH stimulated other follicular growth, thus suppressing the growth of lesser follicles and allowing the dominant follicle to emerge. Whereas in PCO and all, there are more number of like primordial follicles, more AMH, so more this thing inhibition will be there. So there will be no proper follicular growth. So again, growth factors, they also modulate this proliferation and all. And insulin-like growth factors, this is important because insulin-like growth factors like IGF-1 and IGF-2, they have similarity to insulin and mediate, because growth hormone can act by mediating through them. So most abundant IGF which is seen in follicles is insulin growth factor 2, which acts via both insulin growth factor 1 receptors and 2 receptors. So this IGF-2 is produced in theca cells, granulosa cells and luteinized granulosa cells. So IGF-2 stimulates granulosa cell proliferation, aromatase activity and progesterone synthesis. That's why whenever during stimulation or so, whenever we give growth hormone, no, so this acts through IGF, insulin growth factor 2 and all. Then again, there is more of granulosa cell proliferation and all. So IGF-1 receptors are present in theca and granulosa cells. So these actions are augmented by growth hormone, which increases IGF production and thus indirectly enhances the gonadotropin stimulation of ovarian follicles. As we can see, so there is IGF-2 production in the granulosa cells. So coming to ovarian cycle, so primordial germ cells. This primordial germ cells, they originate in the endoderm of the yolk sac and hindgut of the embryo. Then this primordial germ cells migrate to the genital ridge at around 5 to 6 weeks. Then again, during 6 to 8 weeks of pregnancy, this mitotic multiplication of germ cells begin. So maximum number of oocytes are seen at around 4 to 5 months, around 6 to 7 million. And at birth, again there will be reduction of around 2 million, and at puberty around 3 lakhs. And so the 400 will ovulate almost during the lifetime. So again, we all know this thing, our meiosis is arrested until ovulation, that is in diplotin stage of ovulation. Then again, first meiotic, during the ovulation, there will be first meiotic division in the adult life. And then after fertilization, there will be second meiotic division and second polar body exclusion. So folliculogenesis is folliculogenesis stages. So some stages like till they are till this secondary antral follicles are FSH independent phase. So whenever the follicles are around 2 to 5 mm, they start developing FSH receptors. Then only from small antral follicles, FSH dependent phase of the follicle starts. So again, there is initiation of follicular development, recruitment, then again pre-antral follicular development, then selection of the dominant follicle and dominance. So this AMH is secreted till small antral follicles, primordial small antral follicles. So first recruitment, it takes so almost around 4 months. So all this primordial, primary, secondary follicles. Then from the secondary follicles, again small antral follicle has to be formed. So for this to get converted into pre-ovulatory follicle, this will again take around 85 days from secondary follicle to pre-ovulatory follicle. So again, this small antral follicles should get recruited. So whichever follicle is good, it should get selected and then attain dominance. All this should happen. So follicle development, primordial follicle development. So first visible signs of follicular development is increase in the size of oocyte, and the granulosa cells, single layer will be there. There will be cuboidal. So gap junctions are there between the oocyte and granulosa cells for the exchange of nutrients. Then this in the primary follicle, then there will be multiplication of this granulosa cells. So then approximately 15 cells are formed. Then we call it as a primary follicle. There will be basal lamina formation. And also whenever there is 3 to 6 layers of granulosa cells, there will be theca cells appearance. Then again, this thing, so there is a concept called as FSH threshold and FSH window. So during the luteal follicular transition, for the recruitment to happen, for the appropriate follicle to be selected, so there should be a proper LH level, and also that proper threshold FSH level should be maintained for a certain period of time. This is called as FSH window. So the duration of the rise in FSH that is above a critical threshold so determines the number of dominant follicles to be selected from the recruited cohort. So this is called as FSH threshold window. So whenever we are in ART, whenever we are stimulating, what we are doing is we are increasing the FSH threshold as well as FSH window so that more number of follicles are recruited so that we can pick up more number of oocytes. Then preantral follicle. This preantral follicle is surrounded by zona pellucida. Then again, there will be multi-layer proliferation of this granulosa cells. So this preantral follicle is around 2 to 5 mm. So here the FSH receptors start appearing. So here from this preantral follicle, the FSH dependence phase starts. So there will be increased gap junctions. So FSH stimulation propels follicles to preantral stage. So the fate of these follicles is in delicate balance because again two cell two gonadotropin theory, then there will be again FSH this thing aromatization of androgens to estrogens. Then after that estrogen production there will be more of FSH receptors increases. So the success of a follicle depends upon its ability to convert an androgen dominated microenvironment to a estrogen dominated microenvironment. Because again if that fine balance is not there in the follicles, so whenever there is more of high level of androgens are there, what it will do is again it will inhibit, there will not be aromatization into estrogen, again it will get converted into 5 alpha androgens. So more of androgenic microenvironment is also not good, it will lead to atresia of the follicles. So there is like concept called LH ceiling, LH threshold, LH window. So antral follicle. Under the influence of estrogen and FSH, there is increase in the production of follicular fluid. So this all follicular fluid will coalesce to form an antrum. So this follicular fluid is rich in hormones, growth factors and cytokines which are required for the maturation and development. So in the presence of FSH, estrogen becomes the dominant substance in the follicular fluid. So whenever there are no FSH, if only LH activity is there, then the androgens predominate, which will lead to atresia of the follicles. So LH is not normally present in the follicle until the mid-cycle. If LH is prematurely elevated in the plasma and antral fluid, mitotic activity decreases, degenerative changes ensue, that is the follicular atresia will happen. So synthesis of steroid hormones functionally compart like two cell two gonadotropin theory. Then recruitment. So whichever follicles which are rescued from atresia will get recruited. So the follicle which is destined to ovulate is recruited in the first few days of the cycle. So the fate of almost all of these follicles. So again, what does this FSH elevation will do in the early follicular phase and all? It will start producing inhibin. This inhibin, what does it cause? It will decrease the FSH in the remaining follicles so that whichever follicle is good, that only will get recruited and selected. The other follicles under all these hormones, they will undergo atresia. So the follicle destined to ovulate is recruited in the first few days of the cycle. The fate of almost all of these follicles is apoptosis unless rescued by FSH. So the ovulatory follicle is one of a cohort recruited at the time of luteal follicular transition. So the time to achieve pre-ovulatory status is approximately 85 days. So now not only we are doing day to start, we are also doing like random start whenever patient is these things whenever patient comes no day 7 or like late follicular phase or late luteal phase also we can start. So this depends upon these theories like antral follicle recruitment theories, like because follicles they have got continuous recruitment throughout the menstrual cycle or cyclical recruitment. Like cyclical recruitment means once in the late luteal phase or early follicular phase of each cycle, or recruitment of 2 or 3 cohorts or waves during each cycle. So like continuous recruitment. Continuous recruitment means these follicles grow at all stages of reproductive life. The follicle destined to ovulate is selected by the follicle destined to ovulate is selected from the continuous supply of antral follicles by being at the right stage of maturity to respond to the rise in FSH. Thus, follicles are continuously available because 2 to 5 in size for a response to FSH. Then cyclical recruitment. So like cyclical increases in the number of antral follicles observed at regular intervals during the menstrual cycle in women. Single recruitment. So these are the theories like how recruitment happens. There can be cyclical recruitment of follicles like in between the cycle like day 2, or there can be continuous recruitment of follicles. So whenever there is availability of small antral follicles, or there can be single recruitment episode. The single increase in the number of follicles 2 to 5 detected after the regression of LH. So this single recruitment, this can be in the late luteal phase or early follicular phase of the menstrual cycle. And follicular phase. So waves like synchronous growth of a group of antral follicles occur at regular intervals during the menstrual cycle. Follicles in each wave are of similar but not identical diameter. So there can be first wave in the follicular phase, second wave in the luteal phase. So that's why this thing dual stimulation has come up. So one they will do in the follicular phase, and then again next stimulation they will do after pickup like in the luteal phase. So development of more than one wave of folliculogenesis during women's cycle provides the possibility of new ART regimens. Then after recruitment, there should be selection of the dominant follicle. So the follicle selection is the process by which a single dominant follicle is chosen from the recruited cohort or wave for potential growth. So the follicle that is selected from the recruited cohort is called as the dominant follicle, whereas all the other follicles of the cohort which undergo atresia have been termed as ordinary, challenger, or subdominant or subordinate follicles. So in the dominant follicle, it will have more FSH receptors, so that little FSH, so that whatever FSH is there, it can only absorb, and then there will be higher aromatase activity and robust steroidogenesis. Then follicle divergence. So the dominant and largest subordinate follicles undergo a common growth phase. So at the time of selection, the growth profile of the dominant follicle, so it is different. It begins to diverge as it continues to grow, whereas the other subordinate follicles undergo atresia. So when do we say it as dominant follicle? So divergence occurs when the dominant follicle reaches a diameter. So whenever the follicle is attaining almost 10 or more than 10 we we assume we know that it has already taken dominance. So that follicle will be like selection dominance. So whenever the follicle is more than or equal to 10 So it happens during day 6 to 9 of the follicular phase in the women. So this is the common growth phase of the dominant follicle, whereas other follicles will be diverging from this growth phase. So atresia of the dominant follicle. So what will happen? Estrogen exerts positive influence on FSH action. So it will cause estrogen like FH surge will be there, and also LH surge also will be there. Exerts this again, it will be this thing positive influence will be there within the maturing follicle, and its negative feedback relationship. So it will have positive influence. This estrogen which is produced by the dominant follicle, it will increase more of FSH receptors on the dominant follicle. So there will be positive influence on the dominant follicle, whereas on the other follicles, it will have like it will deplete the FSH receptor and all on the other non-dominant follicles. So there will be withdrawal of gonadotropin support. This fall in FSH leads to decline in FSH dependent aromatase activity. So all these activity will be declined in other follicles, limiting estrogen production in the less mature follicles. So there will be an irreversible androgenic microenvironment will be there, more of that in the non-dominant follicles. So it will undergo an irreversible heterotic change. So in the late follicular phase, what will happen? So this dominant follicle must escape the consequences of FSH suppression induced by its own accelerating estrogen production. So what will it do, this dominant follicle, because of this more estrogen production, no, more than around 200 250 mm for around 40 hours, it will cause LH surge, pre-ovulatory surge will be there. So in order to respond to the ovulatory surge and to become a successful corpus luteum, again this granulosa cells, it should also acquire LH receptors. So this FSH induces LH receptor granulosa cells in the large antral follicle. So with increasing concentrations of estrogen within the follicle, FSH changes its focus of action from, so this, what does it FSH do? It will also help in the activation of LH receptors, secretion of this thing LH receptors. So LH formation of its own receptor in the FSH primed granulosa cell. And also there is one more factor called as gonadotropin surge attenuating factor. So whenever in the early follicular phase, no, for the surges not to happen, this surge attenuating factor will be more. So whenever the estradiol level increases, whenever the follicle is around 16 to 18 mm, so that's what where during ovulation will happen, no. So before ovulation, whenever estradiol level rises, no, this surge attenuating factor should decline so that surges should happen. So a hypothesis has been developed that the activity of GN, surge attenuating factor, in the circulation is high during the early and mid follicular phase, and this maintains the pituitary in a state of low responsiveness to GnRH. So the positive feedback mechanism. So all this estradiol, progesterone help in LH surge. So attenuating factor must be low. Then after that, again, this after LH surge, no, progesterone, everything will be there. Then again, pre-ovulatory follicle, then granulosa cells enlarge, acquire lipid inclusions. All this will happen in the pre-ovulatory follicle. So theca becomes vacuolated, vascularity will be more. Then the oocyte precedes in meiosis. That is, it approaches the completion of its reduction division, because after ovulation only the meiosis one should be completed. So there will be more amount of estrogen. So during the late follicular phase, the estrogen rise slowly at first, then rapidly. So estrogen peak reaches almost 24 to 36 hours prior to ovulation. So there is a peak, almost approximately 24 to 36 hours prior to ovulation, there is estrogen peak. So the onset of LH surge occurs whenever there is more than 200 picogram for around 48 to 52 hours estradiol, whenever it is maintained, no, then only LH surge happens. So the LH surge seals the fate of the remaining follicles, lower estrogen and FH content that is in the less dominant follicles. No, this LH surge causes this thing, lowers estrogen and FSH, and also it promotes in the dominant follicle luteinization of the granulosa, resulting in the production of progesterone through its own receptor. So progesterone at mid-cycle is responsible for the FSH surge. So this thing before ovulation, no, two surges will happen: FSH surge as well as LH surge. So estradiol helps in LH surge, whereas mild elevation of progesterone helps in FSH surge. So progesterone affects the positive feedback response to estrogen. So in the presence of subthreshold levels can induce a characteristic LH surge. So when administered before the estrogen stimulus, whenever this thing progesterone, whenever it is administered in high doses, no, before this estradiol peak, it blocks the mid-cycle LH surge, because only small amount of progesterone is needed for FH surge as well as LH surge also. So this is also important. LH dependent phase of pre-ovulatory follicular development occurs only if LH is present at concentrations within the LH window, which is above the threshold and beneath the ceiling value. So low level of LH, so there should be threshold of LH, because low level of LH it is also not good, because it impairs follicular growth, oocyte maturation, inadequate androgen and estrogen synthesis, whereas optimum level should be there. So around 1.2 to 5. Optimum level for optimal follicular development levels should be above the threshold but below the ceiling. Whereas high level of LH, like in non-dominant follicles, it will cause atresia, oocyte development compromised, like premature luteinization, suppression of granular cells, all it causes. So, what does LH surge cause and FSH surge cause before ovulation? LH surge causes resumption of meiosis in the oocyte, whereas FSH surge, it frees the oocyte from follicular attachments, like free floating oocyte in the antral fluid. LH surge causes cumulus expansion, whereas FSH surge also causes cumulus expansion. And LH surge, there will be utilization of granulosa cells to secrete progestogen, appearance of progestogen receptors, whereas FSH makes sure full complement of, that is, it complements the LH receptors on granulosa cells. So there will be prostaglandin and icosanoid synthesis, like follicular rupture. So prostaglandins are important for ovulation, whereas FSH surge, this causes follicular rupture, like plasminogen, plasmin. So LH surge also causes this corpus luteal steroidogenesis. So ovulation. LH surge happens almost 36 hours prior to ovulation, whereas LH peak happens 10 to 12 hours before ovulation. And ovulation happens approximately 10 to 12 hours after the LH peak and 24 to 36 hours after the peak estradiol levels are attained. The onset of the LH surge appears to be the most reliable indicator of impending ovulation, occurring 34 to 36 hours prior to follicular rupture. So a threshold of LH concentration must be maintained for about 14 to 28 hours in order for full maturation of the oocyte to occur. Usually the LH surge lasts for around 48 to 52 hours. So whenever this thing to monitor ovulation, we sometimes we also advise like LH kit test. So LH kit test, no, at least 2 to 3 days before, whenever we suspect ovulation, no, from that time we should ask them to start using LH kit test. So the problem is LH peaks, no, it might not be able to detect. So whenever they are using LH kit test, no, we can ask them to use like 2 times a day also to detect this surges and peaks. So LH meiosis resumption. It causes breakdown of the gap junctions, reduction in cyclical AMP. Then all this fall in inhibitory action of this maturation inhibitor. So overcomes resistance. All it does, which helps in the meiosis resumption, LH. So FSH, LH and progestogen stimulate the proteolytic enzymes, so which help in the digestion of collagen in the follicular wall and increase its distensibility. So all this LH surge, this thing FSH surge, all it will help this thing progestogen rise. So prostaglandins mainly help in contraction of smooth muscles, disruption of follicular wall. So this thing extrusion of the oocyte cumulus cell mass. So what we should remember is ovulatory role of prostaglandins is so well demonstrated that infertility patients should be advised to avoid the use of drugs that inhibit prostaglandin synthesis. So whenever we are doing this ovulation induction cycle, and whenever we are noticing any luteinized unruptured follicle, no, this history also is important. So whether patient has taken any painkillers or NSAIDs during that time, so which inhibits ovulation, so we don't know. So we should tell them that NSAID should not be taken whenever they are planning pregnancy, mainly during the ovulation period. So decline of LH surge. So within hours after the rise in LH, then there is a drop in the plasma estrogens, the decrease in LH. So there is a loss of positive stimulating action of estradiol. So increasing negative feedback of progesterone. So depletion in the pituitary LH content due to down regulation of GnRH receptors. So after this LH surge, no, this luteal phase start. So granulosa cells enlarge, have vacuolated appearance. This yellow lutein pigment will be there. So theca cells differentiate from the surrounding theca to form part of the corpus luteum. So all this angiogenesis, everything will happen in the luteinized granulosa cells. So day 8 to 9, vascularization is maximum. So steroidogenesis needs continuous tonic LH secretion. Corpus luteum declines by 9th to 11th day after ovulation. So angiogenesis is mediated by all these VEGF, angiopoietins, everything. So by day 8 or 9 after ovulation, a peak of vascularization is reached associated with peak levels of progesterone and estradiol in the blood. Then again, luteofollicular phase transition. So again, what happens before the menses and all, there will be intercycle rise of FSH starts 2 to 3 days before the onset of menstrual period, and it ends in the mid follicular phase of the next cycle. Whereas this FSH, no, peak which starts 2 to 3 days, which starts rising before the menses, no, it maintains till the mid follicular phase. It is a result of the significant decline in estradiol, progesterone, as well as inhibin A concentrations towards the end of. So, means it happens because of estradiol, progesterone, inhibin A concentration towards the end of the luteal phase. So, there will be a no negative feedback mechanism. So, this is a summary of ovarian events like this thing, menstruation, there will be increased FSH, then FSH induces increased estradiol secretion, then again it will cause positive feedback, then again ovulation will happen, then will be there, then again after this 9 to 11 days after ovulation, then again there will be atresia of corpus luteum will be there, then again decreased secretion, then there will be no negative feedback, luteofollicular transition will be there, menstruation will be there. So this is this thing, day 1 to 4, what will happen, ovarian events, recruitment, endometrial lining sloughs. So all the hormones will be low. This thing P4 low, whereas FSH and LH will start in. So 5 to 12, there will be dominant follicle will be seen. So more E2 growth of stroma glands will be there, like follicular phase, increased E2 and inhibin. This will again inhibit FSH changes. So LH will happen, then corpus will be formed. Then this is the second endometrium. Then P4E2 secreted, FSH and LH secretion will be inhibited. Then again luteolysis will be sloughing of endometrium. Then again these hormones will decrease, FSH begins to rise. Thank you. Hello? Yeah, any doubts are there? This regulation of menstrual cycle, no, again you have to read. It's better to read
where
Spiroff.
should we read it, in Spiroff or where?
Spiroff is good.
because it's so much in there.
There will be so much of neuroendocrinology. First, you have to understand. Then this primordial follicles, how recruitment, selection, dominance will happen, and about all these hormones. No, Spiroff has given beautifully.
Yes, yes, ma'am. That's
You
what.
have the time to read Spiroff at least once.
Yes, I think he in the Spiroff it is clearly explained and all.
Yeah, it is clearly explained.
So this would
Reading.
rather help in tuning the medication for this proper getting a proper
Because
follicle.
why we are giving that much FSH, LH. So when we should give all these things, no, early follicular phase, FSH is important. Whenever the follicle attains 12 to 13 no, there will be LH receptors also will be acting. So then if we give in the mid-cycle this thing HMG, then it helps more. Again, you can also give growth hormone because again insulin like growth factors, everything will act.
Yes, yes.
It helps in granulosis, proliferation, all these things, no, you can correlate.
Yes, ma'am.
And also, whenever no this thing during stimulation, we can do pick up 36 hours also, 37 hours also, because usually here we do pick up at around 34 and a half hours after giving trigger. So
Okay.
if you want to like do 36 hours, 37 hours, no, again you can give NSAID to prevent this ovulation.
Okay. Oh.
So all this will be there.
Do you give NSAIDs on a regular basis, ma'am, to prevent
No,
ovulation?
NSAIDs usually we don't give on a regular basis because usually 36 hours this thing ovulation will happen, we think, and we schedule our pickups like 34 and a half, like 35 hours only. If we finish up doing the pickup, only when patient is like POR patient, poor ovarian reserve, no, there are more chances like premature ovulations will happen mostly. Then we can give that NSAID.
So in
Like
those selected patients, you give very
selected patients, if we suspect that if only 2 eggs or 3 eggs might rupture once, like before 35 hours only, then we can give.
So it's like you do batch stimulations, madam, so that you can do a batch.
No, batch we don't do. Batch stimulations, no, usually agonist protocol works. Contact protocol, it's difficult to do batch stimulations.
Okay. So there's lot into this. We have to only when we are thorough with the physiology of all these things of folliculogenesis, I think only then we can understand.
That's what you have to
Yeah,
read.
ovulation induction properly. For different things. Ovulation induction in a like normal cycle, like where we are doing ovulation induction with follicular monitoring and timed intercourse, ovulation induction for IUIs and for IVF. So different.
That's what.
Yeah.
You have to read. Okay. If you have anything, just message, no, because
Sure,
again,
ma'am.
Jyoti has to take some class, I think.
Sure, ma'am. Thank you, ma'am. Yeah.
Yeah, thank you.